Okay. I'll also just keep an eye on the chat for any questions that they might post there. And then Eve, are you now already the president of
I'm already,
the...
yes, 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 I'm already.
Yes. Okay, because in your bio it said will be,
Yeah,
but I
I'm
assume
already.
that you already are.
I'm really it, yes.
Okay.
I have everything here now. Yes, on paper.
Ah, good old paper.
Okay, it came out.
Okay, so now I just want you to share your PowerPoint again. Remember, the PowerPoint is still open. All that you need to do is go to the green share button in Zoom, click on it,
Wait,
and
wait, wait, wait. No, no, I have another problem. No, I'm too small. Yep.
you can now make it bigger again, remember, because now you've got your notes next to you. And when you start presenting, your camera is quite small, so people won't see if you look, and you've got your notes in front of you. So, perfect. And there you
Okay,
are.
no,
100%, just move from the next slide to the next
but
slide.
where is my PowerPoint now? I don't see it. You said perfect, but I just see you and Gobut and
You should see it. Just make your zoom a bit bigger.
nothing. Honestly. I see Zoom Workplace, AA Company, and then you. That's the only one that's the only thing I know myself.
You might have minimized zoom.
No, I didn't.
What do you see? The camera. So remember on Zoom, the new Zoom, there's a webinar. Right on top, there's a webinar icon and a screen.
Yeah.
Click on the screen.
My screen. I click on my screen.
Yeah, it says Dr.
Okay.
Got it now.
And what do I see now?
I don't know.
Oh
What
no,
is
it's not what I wanted. I see my PowerPoint presentation and a PowerPoint presentation that I cannot even open. That's
that?
really not what I want to see. Webinar again. So
I'm
Dylan,
I'm stopping you from sharing. Okay. So let's just start sharing again. Go to share button.
share. PowerPoint.
Choose your PowerPoint.
Dylan.
Okay, now it's shared.
I don't see it.
Okay, so if you come right, Eves, let me share for you.
I have something, but very small now.
Okay, but it's big for us. It's big for us. So let us just try alternative method 2. So
Yeah,
what
no, it's okay. It's okay. I have it back. I have it back and it's okay.
Okay, but I'm going to stop you sharing and then I am going to share so that if we need to do this, you are okay. So I'm sharing now. You should see my screen.
Yeah, I see your screen.
And then I'm just going to progress when you say to me next slide.
Okay, but it will work, I think. Yeah, okay, perfect.
We do it this way.
Yeah.
Is that
So
easier?
no. I will do it from my screen. That's okay.
Okay. So what we say to each other, if you struggle at all, then I'm going to start sharing.
Yeah.
And my next slide, I'm ready to do it immediately. Otherwise, you are going to share. So just you can quickly share again.
Okay, I know you have it.
And there you are. Yeah.
Okay.
The display mode now is different than the previous time. So this is the perfect display mode.
Mm-hmm.
And then you just move to the next slide, either with your keyboard or below the button. There's that and backward. Okay, there you are.
Okay, it works.
Perfect.
Okay.
Good. So I will have to stop you from sharing because I need to play the entry video. So, but
Okay.
let us do it once more, just for a last time. And then I just want to make sure that we've got all your notes because I did it in
No,
quite
I
a.
have everything. I have everything. I can see it.
Okay, perfect.
Mhm.
So I remember if you struggle at all, you're just going to say, please share my PowerPoint and I
Yeah,
will.
no problem. I will do that.
Okay, perfect. Good. Have you been to South Africa, Is?
Please?
Have you been to South Africa?
Never.
No.
I'm not invited by Kobus.
Oh,
Oh, shame. Shame. Yeah. Yeah.
He
Marlene,
always
that.
said he always says that I have to go to his bruifiest, but he never invites me.
Yeah.
now we need to sit. This is not South African hospitality. Huh? You're too busy.
Yeah.
No. One day it will happen for sure.
All right.
Do you only do I haven't read your CV. Do you only do wildlife, Is
No.
or
I only do dentistry.
okay. So we
Yeah.
must invite you sometime for a small animal thing.
I do 70% small animals, 30% wildlife.
Fantastic. So we must keep
Yeah.
in contact if you're interested.
I'm always interested.
I will ask Dr. Raad to organize the post safari for you. But I'll get
Mhm.
huh, Cobus?
Yeah,
Perfect.
definitely. Definitely.
Definitely. No. I'm a small animal veterinarian, dental veterinarian. I do a lot of surgery, jaw surgeries, tumor surgeries in small animals, and 30% is wildlife, and the wildlife goes from hedgehog till elephant.
One. Fantastic.
So with Cobus, I only did the big things, I think.
Monique, you muted.
There we go. Eve,
No,
which is your favorite to work on?
everyone asked me that. My favorite is the one you do for the first time, but the one I learned the most of in wildlife is the walruses in Paradisa, because there I had to listen to the zookeeper, to the trainer, and they learned me a lot because it's not only dentistry; it's also listen to the trainer, to the ones like for the elephant in Vietnam, you have to listen to the mahout. It's not just us; it's the whole team. It's not only me who's doing dentistry or you're not the one who is doing anesthesia. It's a group of people who is working, and you have to listen to everyone. And my favorites are still the walruses because that was really fun. But elephants are fun too. So the more you do, the more you come that you get used to it, the more fun it is.
That's great.
So this nice view is just to make me jealous, isn't it?
Yeah.
That's a picture of my backyard.
Okay, thank you. Yeah. I'm living in Flanders. That means that if you have a backyard of 2,000 square meters, that your backyard is already huge.
Mhm.
Well, you know, Yves, that life is about choices. I say life is about choices.
Yes, constantly.
Yeah, it's your choice. Don't cry like a baby.
Yeah.
Thank you very much for the cameras and sound. Hey, Malin.
What is it?
If you can move us and take our hands away, you have to do it.
Your sound is suddenly not good.
That's that.
I know it's your internet. If something goes wrong, I will put off your camera.
Yeah.
Just, Kobus?
Yes, can you hear me?
Yeah, I can hear you now.
Okay, I'll just speak straight into the mic.
Yeah, please. Just we'll tell you if it's wrong. Okay, so I'm gonna start with a countdown. I just wanna get the second computer must come in.
Do I have to share again?
No, we are now gonna start with a webinar and play the intro. Okay.
Mhm.
Everybody can just mute themselves and put the cameras off. Okay, we are starting. Good evening. We are just going to give everyone a chance to enter the room. Welcome to the webinar tonight. We'll start shortly. Monique, you just need to unmute. Just a second, just a moment. Thank you.
There we go. Let's try again. So a warm welcome to everyone joining us from across the globe for this, our last webinar of 2025. I've had a sneak peek of the presentation and I guarantee you we are in for a treat tonight. The webinar is CPD accredited, so a link will be posted in the chat. Just follow the link, complete the form, and then you will get your CPD points at a later stage. If you have any questions or comments, please pop them in the questions in the Q&A section and any comments in the chat section, and we'll address those during the Q&A session after the presentation. So in our last webinar, Dr. Alex Semjonov and Dr. Kubisrov focused on anesthesia during dental procedures. And tonight we're going to go a bit more into detail by focusing on tusk problems in elephants. So we're pleased to have Dr. Yves Debauchet sharing his knowledge on this topic with us tonight. Yves graduated from the University of Ghent and has worked in a mixed equine and small animal practice. He did that for almost a decade before he started his formal training in veterinary dentistry. And as his passion for dentistry grew, he later pursued advanced education in dentistry and oral surgery. Since 2018, he's run his own consulting practice, focusing on companion animal, wildlife, and zoo dentistry. And since 2024, he's served as a wildlife dentistry consultant for Sovereign Consultancies. Yves has been a board member of the European Veterinary Dental Foundation since 2015, and he was appointed as the president of that foundation this year. So Yves, over to you.
Thank you. I will try to share my screen so that you can all have it. Good evening to everyone, or good morning to everyone, depending on where you are in the world. Tonight, I want to talk about more tusk problems in elephants, because it's something we see very often in the wild and in captivity. So, if we are speaking about tusk, first of all, we need to know what a tusk is. And in Proboscideans, it's a maxillary second incisor, and it's a very compact dentine who is typically ivory. So if you look at the picture on the right side, the left picture is from an elephant, the right one is from a walrus. Then the walrus that you see that the center part of the dentine is much more porous, that is osteodentine, and that in the elephant it's much more compact. We will see why that is, but that is the adaptation of the animal, why they have to use their tusks. If we speak about elephants, we have two big species, the African elephant and the Asian one. If we look at the African elephant, both sexes have tusks. And in the male, they are longer and more conical than in female. So that is also a challenge. If you have a male African elephant, this conical part is much more difficult to extract than in a female or in an Asian elephant. They grow continuously throughout life in both animals, but in African elephants, they weren't grown faster because they use it for more heavy work like digging, stripping bark, and all this stuff. On the right side, you can see Dida. Dida was known for her longest tusk. She died, unfortunately, in 2022 at the age between 60 and 65, which is for an elephant in the wild already very, very old. So if you look at the African elephant, we have the savanna elephant and the forest elephant. Only the morphology of the tusk is different, but the constitution of the tusk itself is exactly the same. So the Asian elephant, there we see that all males normally have tusks and only 50% of the females have tusks. And of the females, the tusks are much more rudimentary, also sometimes referred as tusk, but that is not the correct term because the tusk is a deciduous tusk in a newborn elephant. They grow more slowly anyway, and they may not work as extensively, but they are smaller and have to do less heavy duty tasks. If we look at the Asian elephant, we have the Indicus, the Sumatran, and the Maximus. What is very strange is that in the Maximus in Sri Lanka, most of 70% of the elephants are tuskless. And we see that it's most the males who are tuskless, and later on we will see that it's a little bit particular because normally the fact of being tusklessness is linked to the X chromosome and not to the Y one. So if we look at the early development of tusk and tusk, it starts very, very, very early in life. So the earliest development of the lamina dura, that is for the part that will start, is at 1 month of gestation. And then the 1 month of gestation is picture P. So that is a fetus of 1 month old. The cap stage will already start at the 2 months of gestation. And it's there that the dental organ of the tusk will be formed. And at the age of, or the gestation of 2 to 3 months, the bell stage will be there, and the bell stage is where everything will start. At the end of 3 months, you will see, and that you see in the lower part where the white arrow is, we will have an epithelial proliferation on the external animal epithelium of the bud stage, and that is already the 2 germ for the definitive tusk. So the tusk itself normally is between 5 and maybe sometimes to 7 centimeters, but it will never erupt through the skin. Like already said, the bud stage of the tusk originates from the cap stage of the tusk, and at that when the tusk erupts, the tusk will put aside and will resorb complete. Still, it is important that we have tusk because, first of all, the tusk itself will orientate the dental organ of the os incisive to create a pathway of the eruption. And we will see in one of the possibilities that go wrong in tusk problems is the laceration. Here, that is already one of the possibilities. If there is trauma to the tusk itself, it can be that the tusk is completely wrong orientated when it starts to erupt. It will also delay the development of the tusk by several months, which is rather important when the elephant is lactating and they have to drink milk. If they have already tusk in the place, it would be very, very complicated for this animal. So if we look at the tusk in an Asian elephant, you can see on the right side the D, that's the ivory, the C, that is the pulp chamber, and N is the nasal cavity. Between the nasal cavity and the apex of your tusk, there is a very, very small area that is between 3 millimeters and a half a centimeter. So you can easily break it if you want to extract a tusk roughly. So you have to be very gentle. You have to know what you do because it can be very, very complicated afterwards, and you can have complications like a neuronasal fistula. If we look at the internal structure of the tusk, that is very typical in Asian elephants. The tusk of a bull, you will see that the pulp is coming outside the lip bowl. So you will have a big part of the pulp coming out, which can complicate, of course, fractures. In a female, here it's mentioned tusk, but it should be tusk. We see that the pulp cavity remains within the sulcus and the lip bowl cavity. So that means that we see much more problems in Asian male elephants than in Asian female elephants. The tusk morphology, so dentine is it's the ivory, like I already said, and it's very hierarchical of composite of biological materials. So it's made of mineralized collagen fiber that you can see this pattern pattern. So this convex lines that you see, that is a very, very compact mineralized collagen fiber. When it's set, it's very, very compact, and that gives the typical aspect of ivory. The ivory itself is very close to a combination of teeth, dentine, bones, and antler because it has to serve like that. If we look at the morphology and the damage control, the dentine will be excellent for compressive strength and resilience. So it will be the fact that we have something like dentine is good for digging and lifting things. And then the mineralized collagen fiber give flexibility and toughness to the tusk, which will act like a shock absorber if they use their tusk to do heavy duties. The tusk design itself, the curved shape, will be in that way that the distributed forces will be distributed along the tusk instead of concentrated to the tusk. So we know if the tusk would be straight, that it will break much more easier than in a curved tusk. And there are also behavior adaptations in the sense of that there are baroreceptors in the periodontal space that give a very good sensory feedback for the elephant, so they can use their tusk really to touch each other or to touch things. And we know also that elephants have a preferred tusk, and we see most of the time that they will break their preferred tusk. So the tusk is like we are right-handed and left-handed. You have a right tusk or a left tusk elephant. If we look to the pathologies that we can encounter and that we discussed today, will be the presence or absence of tusk. Yeah, presence is not a pathology, but rather an absence is a pathology. Pericoronitis that we see very often, delaceration, supernumerary tusk can occur, but that is very seldom. We will see cracks and fractures, and we will focus most of the cracks and the fractures and what we can do with that. Avulsion is in italics because I know that it's possible. It is described, but I never saw it. And knowing from Gerard Steenkamp, he only saw it once. So he has a picture of it. I don't, but it can be that avulsion occurs. If you look at tusklessness, you have to see that if an elephant is tuskless, if you look at the image of this elephant, you see it's a female elephant, but you cannot see an alveolus. And if you see an alveolus beside the start of the trunk, then you know that this elephant wasn't tuskless, but that he lost his tusk. If it's flat, like you see in this elephant, then you know that the elephant is tuskless. And we saw in the Mozambican war that there was a rapid decrease of the population, of course, of elephants because they hunted them for the ivory to finance the war. And what they saw is that afterwards, and during even the war, that there was an augmentation of tuskless elephants. So more than half were tuskless, and these were not shut down for their ivory, and they could keep on living. But afterward, we saw that the tusk animals went up again. But of course, tusklessness at that time was very convenient not to be stopped during the war. So if they look at what happened, they saw that out of the females that had two tusks, that the majority had tusk and some were tuskless. But the offspring of one tusked and tuskless female elephants were much more tuskless babies coming out. And then on the right slide, part of the slide, you could see the maternal phenotype. What we saw is that if they were tuskless, the majority were female. So if they were tusked, the majority were male. And out of that, they just thought that the fact of being tuskless was linked on the X chromosome and was male lethal, so that the males could not survive and more females were born. The second thing we see more often is pericoronitis, and pericoronitis is inflammation below the lip bulb. So if you look at the center picture, you can see that cheesy-like stuff coming out of the lip bulb. It's very, very smelly, and that is an inflammation of the attachment of the tusk in the lip bulb. The etiology is most of the time trauma and sometimes a foreign body. On the left side, you can see an elephant. You can see abrasion on the right tusk of this elephant. It's an elephant that I treated with pericoronitis. And the thing is that every night when she had to go into the enclosure, she started to fight with the other elephants and hit her tusk against the bars of the enclosure. And each time she does that, then you have a small movement of the tusk. You can have a little small detachment of the attachment, and infection can enter and give pericoronitis. So the treatment of pericoronitis is easy. You just have to wash it and flush it with chlorhexidine twice a day in the beginning, and after 2 weeks you can go to once a day, rinsing it with chlorhexidine, and afterwards just keep it clean and make that your elephant is not hitting the board anymore. But it's important to know that things like that can happen. The laceration is, well, it's an abnormality, but it's not so bad. That means that the tusks are growing in an abnormal direction. We can all see that. The etiology is it's unknown. We don't really know why, but trauma can be a possible cause. And as I said in the beginning, if we have trauma to the tusk, it will direct the growth direction of the tusk, and we can see that already at that time we can have differences in growth direction of the tusk. Supernumerary teeth happen, and it's not due to trauma, but that were elephants that were four tusks. Um, they were hunted in the beginning of the 20th century. And the fun part of that is that I saw it the first time in a lecture of Gerard Steenkamp, and I thought I have to look it up because that's something very strange. And the good thing is that this skull was given as a present to the Tervuren Museum, the Africa Tervuren Museum. And as I live in Belgium, the Tervuren Museum is literally at 60 kilometers from my door. So I wrote a letter to the conservator of the museum to ask if the skull was still there, and as a matter of fact, the skull is still there. And we found out that there is another skull there, and well, not in Tervuren, but in Paris, that is also forecast. So what we want to do now is see if we can still get DNA and see if there is a relation, because we believe that at that time there must have been more forecast elephants, because the local tribes at that time gave a name to this elephant. They called it, like you can see, the Tiamba, and you were haunted or cursed if you dare to kill a portrait elephant. So if they give names to it, and if they believe that you are cursed, if you kill it, there must have been more than that. So we want to see if there is a relation between this animal. And then crack. Crack is something I see very often, and it's always due to trauma, and it's very difficult to stop. And I believe that cracks are the start of fractures. Cracks, in my opinion, start due to microtrauma on microtrauma on microtrauma on microtrauma. So it's not something that happens just like that at once, but if they hit their tusk often against the same object or a hard object, at a sudden time it will start to crack. And the difficult thing about cracks is that we don't know how deep that goes. If it's a crack that it's not going to the pulp cavity, there is no problem. So nothing will happen because the ivory will keep out infection going inside, and there will be tertiary dentine or ivory set against the wall of the pulp that will prevent further cracking. But if the crack goes till the pulp cavity, then you really have a problem because infections then go in, and we can have sulfitis. There have been proposed several treatments for crack. One of them is using rings, but we know that using rings is of no use. It will crack further. It will not stop cracking the dust. There is also a paper that has been published of the use of composite materials. Of course, it looked very fine, but we didn't have any evidence after war that the composite went deep into this crack and could prevent further damage. Of course, this elephant didn't crack further, but we cannot prove that the crack was going deep and that the composite is deep enough. So, in our opinion, if you have real or severe cracks, you should be prepared for VPT, and VPT stands for vital pulp therapy. That means that we have to cut the tusk 2.5 centimeters behind until there are no more cracks. So you cut further and further and further till you don't see cracks anymore in the occlusal surface of the tusk, so in the ivory. And if you don't have to cut into the pulp, there is no problem. But if you have to cut into the pulp and the pulp is open, then you should be prepared for doing a vital pulp therapy. So the fractures itself, if you look at tusk fracture incident, that the study that has been performed by Josephine Rose, I think that Some of you will have take part of this study or already filled in the questionnaire about the study. But if you look at that in managed elephants, we see that it's up to 80.5% that we have dust fractures, and free ranging is 1.3%. Lately, I spoke to the vet of the Kenyan Wildlife Center, and he said that in Kenya they see dust fracture once a day, and I think that can be right if you see that the free ranging is 1.3% of possibility. If you see the number of elephants they can have, it's normal that you can have one a day. And even there, they see it as a problem because they see elephants dying from dust fractures. So if there is an open pulse and there is irreversible sulfitis and infection, they see that the elephants die from that. So they are also interested to see what the possible treatments are for these animals. There are no causes of that, and the most important one is conspecific interaction. I know that some will say, no, we don't do that, but in some zoos, African and Asians will be put together, and they don't get along so well, so they start to fight, and that happens. What we also see is that the musk in African and Asian elephants in managed conditions starts much more earlier than in the wild. For Asian elephants, it should be around 14 years, and African between 13 and 18 years, where in the wild, it's much more than 25 years because there is a presence of dominant bull. And if there is a dominant bull, you will not start to fight. We also know that the tusks of these young elephants are not so resistant to fight as they are of this large big bull. So they break their tusks much more easier than the large big bull. It's also because they strike against enclosures. So the enclosures are made of steel bars because we have to keep this elephant safe from us, or we have to be safe from them, as you want to see it. But nevertheless, they can strike against it and break their tusk. And then there is sometimes entrapment in the enclosure, or when there is enrichment, that there is entrapment of the tusk and that they can break. If you look at the length of the tusk, that is of little influence. It's not because there is a large tusk or a long tusk that they will be much more easier to break. What we also see, and that it was in the Ithaca Park that they saw it, that there is a direct correlation between rainfall and the dust fracture. So they saw when it was very, very dry, that there was much more dust fractures than when it started to rain. And we saw that from 500 millimeter rain, it becomes quite wet, and there is much less, fractures that we see. So we don't know. Has that to do with humidity? Has that to do with nutrients, with fluorosis, with behavior problems? That is something we don't know. So if we see fractures, we have to classify them. And the classification, there is a big discussion happening now between, let's say, the dental vets or the treating vets of elephants with dust and molar problems in how we should name it. And I will start with the AVDC classification. AVDC stands for the American Veterinary Dental College, and they classified dust fractures like that, where the first one is the animal infarct, and of course we will not see that directly, but that you have a tooth fracture as an animal fracture, so that animal is broken. As there is no animal in elephant, that we had only animal at the top. That is not happening, but the next ones are happening. So we have an uncomplicated crown fracture. That means that the crown is broken, but the pulp is not open. We have a complicated crown fracture. That means that the crown is broken and the pulp is open. We have an uncomplicated crown root fracture. That means that the root is fractured also, and it goes underneath the gum line, but there is no pulp involvement. You have a complicated crown root fracture, and that means that it's an oblique fracture where the pulp is open, so the pulp is involved. It goes under the gum line, where you have also involvement of the root and the crown, and then we have a root fracture where there is a fracture of the root itself. And that is the one we want to use it, but if we read the study of Rose, and there were also comments on that, but that's what went on, is that he classified the test practice in class 1, 2, and 3, I think that we should be able to use both for the moment, but know that we should go more to the ABDC classification than to this one. So where for her, a class 1 was only involvement on the ground, a class 2 was an oblique fracture going under the lip hole, but not involvement on the ground, and a class 3 is that there was an exposure of the pulse. Why didn't he speak about the uncomplicated or the complicated Crohn root, the complicated Crohn root fractures, excuse me, or root fractures itself? Is because it's very difficult for radiological examination. But in my opinion, it's very difficult to have radiology of the apex of the tusk because it's very difficult to pass the skull of an elephant. So we will not be able to see it. But most of the time, if we have tusk fractures, we still take pictures or X-rays of the alveolus. And lately, I did an elephant with a root fracture where we could really show the root fracture on an X-ray. So I think it should be possible. And it's up to us or up to you, the people who are involved in the zoo, to train the animal or let the animal train to take X-rays so that we are able, if something happens, that we can take X-rays. It's very, very important that we can see what we will do. The treatment option. Flushing and test debridement with a big question mark. I just put a note of treating that there. It's of no use that you read it. But know that flushing and test debridement will never, never work. Sooner or later, it will end up with extraction. It's impossible to clean the dust out that you will have a complete healing if the opening of the pulp is big enough. There will keep on bacteria going inside. You will have an irreversible pulpitis, and if you have an irreversible pulpitis, it will not heal. So why is it still widely accepted among zoo veterinarians? I think it has to do with a paper that is by Weissengruber, where he said that the vascularization and the structure of the pulp may explain its very good healing ability following injury and inflammation. Which is true, but stipulated also directly that further research is necessary, particularly in injured dust pulp, because we need to know what is going on, and most of the time it's not healing. So maybe we can have an anecdotal case, but most of the time it's not healing. So other treatment options are vital pulp therapy. So that means that the remaining pulp either non-inflamed or must have the capability to heal. We need to properly control the hemorrhage, which is extremely difficult in elephants. So on the left side, you can see the pulp hanging out. So we have to cut this pulp out, and then we have to control the hemorrhage. Then we have to applicate a biocompatible regenerative capping material, which can be MPA, which can be calcium hydroxide, we can be Portland cement. Again, we can have discussions about that, and discussions are going on between veterinary dentists on that. But it needs to be biocompatible and needs to be a regenerative capacity, because we need the dentinoblast to be stimulated to form a dentine bridge, so that there is a plug coming in, that that infection is not going up again. And then after that, we have to put a bacterial tight seal. That can be a Teflon screw that we put composite on top. It can be composite on top. It can be calcium hydroxide on top, and then composite, whatever is possible. But the question is, when should we do it? Should we do it 24 hours, 48 hours, or longer? We really don't know. We will see in a study from Rose what is possible, but I know from colleagues that they say that they even have good results after 1 week or 2 weeks. But I think we shouldn't wait longer than 2 weeks to do it vital pulp therapy. And let's say that the rule of thumb is the sooner you can do it, the better the results will be anyway. And then the next question is, how do we follow that up? The follow-up must be also with X-rays first. And you can say, yeah, but as long as the tusk is growing, it's okay. Well, it's not. The tusk will keep on growing even if a pulpitis is installing. The only thing we don't know is how long will it keep on growing. And what if it suddenly stops growing? And that sometimes we see that it grows, and then it stops. That means that there is something going on inside this test. You can see the EDV guidelines if you have your cell phone with you. You can scan the QR code. We have guidelines set up by the Elephant Dental Vet, it's a group that is formed out of EASA, where we have a consensus of what you should do with broken tests. It's a real consensus, so it's getting out of a long discussion. So maybe someone will not 100% be agree with what is stipulated there, but it's a consensus of several vets, also with two vets, and see where we can get. So please scan it, and you can download the EDV guidelines. Other treatment options are extract, and extractions we have a few. We have the infused tusk extraction technique. That is that they put a rubber ring around the tusk, and then every day they hammer it a little bit further inside. Excuse me. The advantage was, of course, or is that it happens in a non-sedated animal. But if that happens in a non-sedated animal, there is a big need for compliance by practical elephants. And also, what we could see is that it was a very long time because before there was exfoliation, so at least 4 weeks. And then on this picture that appears now, you can see the apex. And if you look at this apex, that is not a nice apex. So I have very big doubts that there is still remaining of dust inside the alveolus. It's almost impossible to check that because you really have to go inside with your hands into the alveolus to feel what's inside. In a non-sedated animal, even if he's tractable and very compliant, I would not dare to put my arm in an alveolus. So I think that is not an ideal technique to deal with extraction. Other possibilities is the one that the Camp is very often applying. And as he said, extraction is a very complex procedure with many complications that should best be avoided. So it's something you shouldn't do directly when you see something. Like, let's say that at the end of my lecture, I would say, don't try that at home because it's not so easy as it looks. And when should you do it? Well, he said if the pulp is necrotic for more than 50%, well, for that we need X-rays because it's not so easy to see that when it's 50%. So he said, well, when I see bleeding pulp, I will try to do a vital pulp therapy. If not, it's extraction. The technique that he used the most before was the internal collapsing technique of Wells. And the internal collapsing technique of Wells is that you just saw part in the wall of the tusk so that it collapsed, and then you can take out part by part by part, and you can see that it's very, very heavy duty work. You can see on A that the saw is going in, and that you can saw the tusk wall into small pieces. I did it once, but the problem is with that you need to use the reciprocal saw, and that in the beginning it's not easy to get good access to your saw line. So it's trembling, it's going all the way. It's not so easy as it looks. So the outcome of such practice in managed elephants, it's also done by Rose. It's done in 35 institutions in 10 countries. They had 79 practice of 64 individuals. There were Asian and Africans. You can see that almost half was right tusk and almost half was left tusk. And that didn't specify, so we don't know. There were 5 objectives they wanted to see. So they wanted to see individual characteristics. They wanted to see which fracture, which class of fracture it was, what it was done with it, medical management of the strategy, endodontic management strategies, and then classify the subsets of the outcome. So what strategy has been done and what is the outcome. So if you look at individuals, you can see that there were much more African than Asian, that the African were adults and that the Asian were juvenile. As you remember that I said that the Asians are coming in much more earlier and that they start earlier to fight and then break much more earlier their test. at that time. So if you see the classification 1 and 2, that means the non-open pulp, that is almost a half, and then the class 3 is the other half. So the half was either an open pulp with pulpitis. And the classification and the outcome, we saw that the class 3 was a sevenfold in African, less in Asian, and that oblique fractures and transverse fractures, that means that oblique is going up, and that transverse is that you can see a flat occlusal face, was more half and half, 44 to 55. And a very important one is the size of the exposed pulp candle. If it's more than a half a centimeter, that means that there is 23-fold more risk of pulpitis. And 23-fold more risk means that this is a 100% risk of pulpitis. And then practice with local infections, 88% of pulpitis and a 12-fold more likely to result in extraction. That means once infection is installed, you don't have any chance anymore to flush that out or to give medication to heal that is impossible. So if you look at the outcomes itself, if you do an endodontic treatment, it's much more likely to heal than medical management. Medical management is flushing and medication. The development of pulpitis is more likely when you do your endodontic treatment more than 48 hours post fracture. So why I said the earlier you can do it, the better. But on the contrary, there was no association observed between the timing to perform endodontic treatment and the overall outcome. So maybe we have some time later on. So much more research should be done on that we can put that in files and see what happens. The use of tap water, on the contrary, significantly associated with the development of pulpitis. And the reason of that is that if you use tap water, that there is a very large accumulation of debris, and that will be flushed in with a large volume of water. So you will induce very easily pulpitis. And also the spigots and the hoses are easily contaminated with feces in an elephant born because they're lying on the ground. They pick it up and then flush all this filthy thing inside the tusk itself. Topical flushing with chlorhexidine or betadine, if it's more than 30 days, you just will have a chance for pulpitis. And they also saw that there was no association between the use of the pulp dressing. So if you use calcium hydroxide, if we use MPA or Portland cement, that it was the exact same outcome. So there is a decision tree that you can have, and you can find it in several books, where I will not go over it, but you can see if it's not exposed, you really have to address behavior. When the pulp explodes and it's bleeding, well, we can try vital pulp therapy. If it's necrotic, you can forget it, or you have to visualize to healthy pulp, and then you can do pulp therapy. But most of the time, it will result in extraction. The best thing that we can do is, of course, prevention. And if we look at this elephant, you see when he lies down that he will start to dig with his tusk, so that it's much more easier for him to lay down with his head. And our elephants are not all capable of doing that when they have to lay down on a concrete floor. So if you look at the enclosures, that is most of the time what we see. Enclosures with big boards and concrete floors, because concrete floors are really easy to clean, and the boards are very safe for us to keep the elephants away from us. But it's much more safer if we can do something like this. Tusk extraction itself, as I already have said, it's the best avoided. And be sure of your diagnosis, because if you start to extract the tusk, you have to come out anyway. Once you start, you cannot stop anymore. And you have to be sure that you need to be extracted. You need to know the length of your root. So you see that in the first picture that I have a probe, that I put it outside, of course, to show you what happened. And then I put some marker to know how deep I can go. And that is what I need when I will use my extractor, that I know how deep I can go. You need, of course, specialized equipment that is homemade. There is no place where you can buy it. It can require multiple procedures, so know that it's sometimes possible that you need to go in a second time, that you cannot take it out in at once, unfortunately. And always be prepared for surprises, because a lot of abnormalities can occur in an inflamed pulp. The inflamed pulp can produce stones like ivory pearls, can do a lot of things. So be prepared of abnormalities. Then once it's out, you have to clean the alveolus, and I clean the alveolus with a garden pressure sprayer. So that goes very deep inside, and then use just 0.12% chlorhexidine to flush everything out. And be aware of complications, like already said, the oral nasal fistula, excuse me, because the the bone wall between the top of the apex and the nasal cavity is really, really thin. So don't hammer in your luxator or extractor just like that. When you don't know how deep to go, you can really hammer it into the nose. And if there is a big oronasal fistula, the elephant will suffer for the rest of his life, because we cannot close it like in small animals. If you look at the X-ray below, that is the root fracture, what I was talking about. So you can really see the fracture and the collapsing of the pieces that are above the tusk itself. So the crown of the tusk that is outside is rather normal, but with a very, very large skull cavity, and then underneath that there was a root fracture. That was an elephant who was treated with vital culture. And then have to know that tooth extractions, tusk extractions are cheaper. So the extraction tools itself, you can see it here. It's made from pipes, made from a lot of things. I go to the grocery store to see what we can have. We have things to take it out. So a lot of things you need to have with you. I use now almost always the closed extraction technique. It's very, very similar of what we do in small animals. So we need to prepare the patient. Radiography can be useful if we have it. The anesthesia performed by a skilled team. And then I start to clean the periodontal space with chlorhexidine, because we need to cut it, and we will never cut in a dirty space. So we have to detach the gingiva. We gently detach it around the tusk with a short scalpel, and then with a periodontal elevator. And then we have to luxate and elevate the tusk. So we insert a modified luxator to break the periodontal ligament, and then we work around. You will see that the first 15 centimeters of my luxator are shortened, so that I can cut slowly around. And the pressure that I will give is really to cut the periodontal fibers. Once it's sufficiently loose, we can put extraction forceps on it, or you can burn a hole through it. I will show both possibilities. You need to put a small stainless steel bar of 18 millimeters at least, otherwise it will bend. And then apply slow but steady traction. Avoid excessive force. Even if you will see that I will use a reject, even then the force is limited. Post-extraction site management, you have inspected the socket for germinal tissue and remove it. Also see if there are no bony parts left, or if there is no test material left, and then flush the socket with stearine, saline, or chlorhexidine. I will never close the socket, because it will heal on secondary intention, and it can take up to 6 months to 1.5 years to close it completely. And in between, you can still have debris coming out of the alveoli. So the first one that I will show is gold. We will not go gold complete history, but that was an Asian bull of 5 years old and 1,000 kilos. He fractured his right tooth 2 weeks earlier before that picture, and then they started to do X-ray and flush it with saline. No X-ray. The text has been adapted. I don't know by who, but the therapy was saline and betadine 4 times daily. And then he showed pain, so they started also to give painkillers, but otherwise the elephant was doing well. So they saw exposed pulp in both tests, but keep on flushing was okay. So if we go further from 2001 to 2022, regular visits were done, antibiotics were given, and flushing was done. They were previewing a vital pulse therapy, but then COVID came and they didn't do it. But at that time, in my opinion, vital pulse therapy was already too late to perform. They placed the rings because the tusk fractured further and further and further, and they removed each time granulation tissue. So if you look at it, that is in the beginning, you see granulation tissue, so it's growing more in. They put the rings on it, so it's the right tusk and the left tusk each time. And then at the end, it looks very necrotic on one side and still granulation tissue on the other side. But you can see that this tusk is really dead and not evolving anymore. So at certain time, there was facial swelling. So that means that really infection is going up. And there was massive deterioration. And then they started to think about maybe the next step and look into extraction. So you see that it's very often that they wait a long time for extraction. So extractions then were planned in April. They stopped in rofloxacin because there was resistance. So if you give it already for 2 years, the only thing you will do with flushing and giving antibiotics is induce resistance. He was doing well, so they kept on doing ketoprofen and then closely monitoring if something happened. That is the report of what we did. So we extracted the two tusks with 3 days difference. The first day we had a meeting to prepare the surgery to see if we could have access to oxygen. Then the second day we did the extraction of the left tusk. So the second and the third day there was post-op monitoring, and then the fourth day we extracted the right tusk. That is what happened afterwards. So they kept on flushing the alveolus when the tusk was out. In the first week, some swelling was seen, which is completely normal. The oral medication was discontinued at then 10, so we gave no more painkillers. That was not necessary anymore. They kept on flushing it every time he came back from the forest to get the debris out, and then little by little we could see that it was good. This is something I don't want to hide from you. That is Cobus taking my material into the forest. It's really funny, but so that's how we have to give it. So we were not really sure if we would see Cobus back at the end because it was that's how we do it. I still have to laugh when I see it. So that's how you have to get your materials up there. So it's not always easy. So if the procedure is not easy, going there is not easy. So how to extract the tusk in 3.4 minutes? I will try to go a little bit more quick than that. But you see, we start to clean everything. Yeah. And then we have someone who asks for a way. So then we cut around with a sharp scalpel blade. Otherwise, it's impossible to go in. And I will cut a little bit quicker. Then we go in with the periostal elevator. This periostal elevator is something I use in large dogs, and it's also used in human medicine. But you see, you can go much further, and then you measure your extractor. That is my luxator, not my extractor. So, and you start to cut in. So the top is really cutting. So I start to cut in. Of course, that is not the biggest elephant, so but we can go around. And then you cut. We cut more. And that is the difficult part. So the lingual part or the inside part you never can cut. So you really have to hammer it in. What I use is a dead blow hammer, so that the force is not directly as hard as we should do with the normal iron hammer. And then you see I can go completely around. So and the tusk is starting to move a little bit. And when that happens, you see it moves a little bit, but that's not enough to take it out. So it's wishful thinking that you can take this tusk out already. And now we will put in the elevator. So we will elevate it and luxate it. So we put more space between the alveolus and the tusk. So we will widen a little bit the periodontal space. And then we hammer that in. Till you can see it moving more and more and more. And if I say you have to be gentle, well, that's my way of being gentle. But once it's done, we can put 2 forceps on it. And the good thing about this forceps is that I can just adapt them to the width of the ivory itself so that I don't have to squeeze it too much. So I can, you see, I can adapt it. And then we start to turn. I will go a little bit quicker, otherwise we will run out of time. And then you put pressure on one side, and you put pressure on the other side, and you count to 10 or to 30 for an elephant because it's much more. And then little by little, it's coming out. And now it will be there. That's it. So if we look at both tests, the left and the right one, you can see that the right one was completely hollow. So that means that this pulp was directly dead and there was not much happening. But on the left one, you can see on the top a lot of ivory pearls. So that means that their infection was going up much more slowly than in the right one. And there was constant irritation of the germ, which make this ivory pearl. So this one was much more difficult to extract because it didn't create directly a vacuum. So the following up is at 6 months, you can see a small hole left and right side, and that is gold showing it, but he's very happy. And then 1 year, it's almost completely closed, and that is gold in his pool. So the second one that I want to discuss with you, and I hope I will get it in 7 minutes, is Taru. Taru is a male Asian elephant of 11 years of 2,300 kilograms. But this tusk was rather big for an animal of that age. It's most likely fractured in July 2024, and we know also that the vital toll therapy has been performed in this elephant. So on the bottom side, you can see an X-ray, and you can see a lot of debris going in. That means that it's open and that also the pulp is open. So we have to see what we can do. Endoscopy and radiography were prepared on different dates, and the outcome was that the test needed to be extracted. Here you just have to see the picture that first of all I cut and then I go in again with my periostal elevator. Then I hammer in my luxator and then we widen the space. You can see it on the bottom with the extractor that you try to widen the space with the elevator. So in this elephant, it was not possible to put forceps on it because that was too big. So we were very lucky that the fire department was there, and to just put slow and controlled pressure on it, we used the jaws of life, and you can see it in the first video that we will put, and then it will stop, so we can control it. Yeah. So then we stop it, and what we will do is that feel if there's enough pressure that you can feel that it's very tightened now. So it's very tightened. And then we do it on the other side, so till it starts to move. And when it starts moving, then we put the bar through it. So you can see and then now he will start with the Rickiac, start to put pressure on it. But that is one that can lift only 500 to 1,000 kilos, so it's not so strong. So and little by little, I will put pressure on it. So we will, when I have just a little bit of traction, yeah, we will start to turn on one side, and then on, yeah, and then on the other side, and then he will, and now he has to put pressure. Yep, and you see little by little. So just by human force, this is not possible. So for the follow-up for Taru was flushing with chlorhexidine the following dose into the alveolus, antibiotic for 7 days and painkillers for 10 days. And this is Taru now doing well with just one test. I have to say, and I see that I'm within time, that nothing works without good planning and anesthesia. Without these guys, that wouldn't be possible. So the first thing is that you know that you have to do that in a team. If you're not confident with elephant anesthesia, it will not work. If you're not confident in putting elephant down, it will not work. If you're not confident in turning elephant, it will not work. So for me, it's the most easy part because I only come in when the elephant is down on the right side, and then I can start with the test. But without this guy, it wouldn't be possible. So no, it's really teamwork. So I have special thanks to Dimitra Dimitriou for the logistical organization of all the things because he takes care of getting all our products there. Dan Wilton, Thomas, Martina Lukmin, Mila, and Fran Pin from animal doctors. And Mila was the one who helped me to get into the alveolus of this small elephant because my wrist was too big to get in. And the crew of Vietnam for their support. Also the zoo of Wood, the Orientarium of Wood. And then my brother in arms, Dr. Kobus Raad and Dr. Alexander Seminov, because without them, it wouldn't be possible. So thank you very much. And I don't know if there are remarks or questions.
I could.
Eve, thank you so much for that presentation. It was absolutely fantastic, very informative. I haven't seen any questions come through on the chat or the Q&A, so I think you probably did a brilliant enough job to give enough information that no one has any questions. Let's just have a look here. If anyone's like me, I always sleep on information and the next day there's about 10 questions that pop into my head. So what I'm going to do is I'll post my email address in the chats. And if anyone has any follow-up questions, please feel free to email me and I can get in touch with Eve and Quibus and give you some feedback.
Monique, there is some questions in the Q&A.
Have they just popped through now? Oh, there we go. Okay, so there's one question here in terms of the antibiotics and which would you recommend to use after tusk extraction?
Well, I have to be honest. I'm not quite in elephant antibiotics. So that is something I always ask to the zoo vet or to Alex that he said what to give. Honestly, in dentistry, we know that antibiotics after extraction is not the most important thing. Like more and more, we start to give no more antibiotics. So I think we should dare also to do the same in elephants because antibiotics will not help them to heal. It's only when we see like very severe and inflamed pulp or necrotic pulp that we will do it, but otherwise we don't. So, but honestly, on antibiotic itself, I'm honest. I have to remain silent. I don't know. It's the zoo vet who most of the time take care of that.
Okay. Then we have another question. So the case studies that you did present were all in very controlled conditions. Do you ever conduct surgery on elephants under field conditions?
Still no, not. But if you see how we can do it, it's very possible to do it under field conditions because we don't need a lot of electronic equipment. So we can do it with the things that are movable, and we can do it under field conditions without any problem. I also saw that there was a question on tetanus, the first one that came in from Alex. Can you comment on tetanus vaccination? So I think that's an important one. We saw that, well, there was one lecturer at the EAZWV who talked about an elephant who died due to tetanus post-extraction. I think if we want to do that, we need to vaccinate them right on and early on, because otherwise we will be too late. So I don't think that vaccinate them just before we will do the extraction is worthwhile. So we have to think about doing that earlier, so that they are vaccinated against tetanus much more earlier than when we have to start.
Okay, Quibus, I think you can tackle this one. What do you recommend as a painkiller during anesthesia, or do you just rely on anesthesia protocol opioids?
Yeah, in fact, we don't actually use opioids in these, except for butorphanol as part of the combination. So what we start off with the elephants, and I think Eve's video may give the guys an idea that this is a quick and dirty operation and then you go, but it could easily go to 6 to 8 hours on a tooth, depending on how big it is. So the anesthesia becomes important, and we normally, because we want to put the animal down on a specific side, we first do a standing sedation of the elephant, and for that we normally use BAM, butorphanol, azaparone, midatomidine combination. Once the elephant is standing nicely, we would put an intravenous catheter into the ear, and then we will drop the elephant with ketamine and have ropes around the legs so that we can determine the side on which it's going to fall, because the dentists obviously want to work on the top tusks. And then we, under field conditions, you saw the ventilator. We always intubate them, and then we have a ventilator on them. And then where we do not, under the field conditions, we then top them up every 20 minutes with some additional ketamine. When we finish with the operation, we do reverse the butorphanol with naltrexone, which is a complete opioid antagonist, which will mean that you will also obviously block all the endorphins, and therefore there could be severe pain for the animal, and therefore somewhere during the operation we start to administer non-steroidal anti-inflammatories. If the animals are used to taking food from keepers and things, then you can start looking at giving them some tramadol or paracetamol afterwards as well, or well, that's what we use mainly for post-extraction pain control. The paracetamol doesn't have much of an anti-inflammatory, but it's more for the pain control. And we take the guidance by the keepers, because pain is not a bad thing. You know, pain is a message, and it's important that you don't completely block it, because then the animal will injure itself further. So we try to wean them off it pretty quickly.
Okay, fantastic. Then we have a question from Nadia. What do you choose to flush the tusks of an old male African elephant that went through a pulpectomy many years ago, but still presents chronic local infection? It's not a candidate for anesthesia as he's more than 60 years old.
That is a very difficult question, in the sense of, as I said, flushing is of no use. You cannot do nothing. It's nothing that you can help the animal with. I think it's much more important to keep him pain-free than try to flush. And of course, if it's for many years, and that's a little bit what is going on now in the dental world, is that this extraction could have happened much more earlier. So flushing If you want to flush, well, don't use chlorhexidine because you will worsen it because it's cytotoxic. Use sterile water or ringer lactate, but for the rest, you will not really help the elephant. The only thing that is possible is extraction. But I understand an elephant of 60 years is not something you are just keen on doing that like on a Monday morning.
Okay. Then we have another question asking, have you performed root canals on molars, or do you recommend extractions?
Well, did I perform root canals on molars? No. And the simple reason for that is the lamellar structure of the molar. So it's very difficult to get through it. If you want to do a root canal treatment, that means that you do the root canal itself. And if you look at the structure of a molar of an elephant, the root itself is very, very deep. So the lamellar structure that is above is not readily accessible for root canal treatment. So if a molar problem is there, I would suggest much more extraction than root canal treatment.
Okay. Quib, is a follow-up question on the pain treatment. Do you worry at all about gastric ulcers with the use of NSAIDs?
Well, you should always worry about that. Yes. And that's why I say we try to wean them off them. The naltrexone has a half-life of about 12 hours in these elephants, and thereafter the endorphins will start to assist you. So it's very seldom that we exceed 3 days with non-steroidals. We also, the flushing helps a lot with that. But yes, you always have to be concerned about kidney damage if you carry on with non-steroidals for not only kidney damage, but also gastric ulceration. And then you don't want to start putting a plaster and get into polypharma and give mirapitant and all sorts of things to now block that. Just wean them off. If your procedure was good, wean them off the pain control. We try to avoid the antibiotic treatment and get the animal into its own routine and carrying on as quickly as possible. There is a question about pearls, Monique, a little bit
Yes.
further up. If the question is, can you say something about ivory pearls? And we've had many discussions about that.
Yeah, well, ivory pearls. First of all, ivory pearls is something that is very normal in older elephants. So we see it very regularly in older elephants. Because at that time the germ is not so active and alive anymore, and we see that the production of the dentine and the ivory is not of the same quality anymore as in younger animals, and so they start to form pearls. On the contrary, if there is trauma, if there is infection, if there is sulfitis, or if there is local insult on the pearl, that also will start to put to make ivory pearl. And then the question is this pearl going to block the pulp chamber or not? We really don't know. Sometimes you're really guessing and seeing what's happening. Sometimes you have to do follow-up and see what's happening because it's indeed a very good question and see about the pearl itself, but it's, most of the time by installed to the pulp or by older elephants.
Thanks for that, Eve. We've spoken about the antibiotics. Just another question about, is it necessary to control the bleeding after an extraction?
The answer is simple, no. No. If you do an extraction good, it may not bleed. It's only during the extraction that it will bleed because bleeding is a good thing for us. That means that we cut the periodontal ligament. If it keeps on bleeding a lot afterwards, that means that you broke the alveolus or that you broke the bone, and that's what we don't want. So if you break the periodontal ligament, you will see very heavy heavy bleeding. You will see some bleeding, of course, in an elephant. That's a lot, but it's not excessively neither. But once the tusk is out, the bleeding stops almost immediately.
Okay. Then, Eves, another question for you. What will be your choice restorative material after VPT?
I used a regular composite that is in bulk that you can put in with large syringes, and that can be light cured. So no, it's a dual cure. That means if you stay, it will harden itself, and if you light cure it, it's going quicker. But what I use is structure C from Vocal. Structure C from Vocal. SPRUCTEUR and then C.
I think that covers all of them.
No, there's still one question. After
Yeah,
tusk
there's still
extraction
one.
and yeah, plus and seal the alveolar socket. No, I don't close the alveolar socket, so I leave it open because there is debris coming out, so it's not blood, but can be debris coming out, and it seals itself because we cannot close that. This alveolus is something like 30 centimeters long or 50 centimeters long. It's impossible to close that, so we leave it open, and it will heal on second intention. But as I said in the lecture, it can take up to 6 months to 1 year, even 1.5 years that it heals completely. But it will heal. You don't have to bother. It will heal. Even if you think after 1 month, oh, there's still debris coming out, don't bother with it. Don't panic. It will heal, and it sometimes stops just in one day. You think, oh no, it's not getting better, and in one day it's getting better.
For all the questions regarding the anesthetic protocols, I would recommend that you watch our previous webinar, where Alex and Quibus actually speak specifically to anesthesia during dental procedures, and they have various case studies in that webinar. I think that covers all the Q&A. As I said, if there are any additional questions that you might think of, please feel free to email me directly and we'll get you your answers. Eve, thank you so much. I know it takes a lot of time and effort to put these presentations together, but I think everyone who joined us tonight really appreciates it. And it's always great to hear from the experts and to get some first-hand information and insights. And Quibus, as always, for standing by with all your anesthetic knowledge and experience as well.
No, thank you
And
very
then also
much.
to everyone who joined us tonight, as long as you guys keep showing up, we'll keep putting these presentations and webinars together. And if there are specific topics you'd like us to cover, as challenging as you might think they are, please share them with us. We always want to share information that you need and that you are interested in. And remember to follow the link to get your CPD certificates or certificates of attendance. The link has been posted in the chat. And I think that's it for tonight. Eve, any closing remarks from your side?
I was very happy to give this lecture. Normally, I give lectures to a live audience. It's very strange to talk to your PC and to keep on track because that's not easy, but it was a great experience. And I just hope, and that's the good thing about the Wildlife Pharmaceuticals webinar, is that we can reach a lot of persons around the world. It's not easy if you do that with a live audience because that is very strict. It's something like a 50, 60 persons from one part of the world that comes to you. But here we have people from around the world. And I think we have to spread the word that we have to help elephants in particular. If something happens with this test, that we don't have to wait, that we have to extract or do a vital cell therapy. But don't wait because waiting is losing time. And I think that is the message that I wanted to give. But we also have to take care of dental problems in all the animals that are around us and to get rid of pain because it's a painful pathology, and it's not good for the animals to leave them like that. So thank you very much for attending, and I hope one day we can maybe meet or help you in doing the job. Thank you.
Thanks, everybody.
Thank you all. Thanks a lot, Yves.